Hi everyone, we're live. This is Dr. Lauren Weissmann in South Jersey Fertility. And tonight's topic is going to be talking about LGBT family building and all the options that surround it. And I really look forward to hearing from all of you and any questions that you might have. This is really your chance to be able to ask any questions that you want, and I hope that it's informative and you guys can learn something that you may not have seen or heard before. All right, so some of the first questions that we usually get asked are, what information do you need to have, or what ideas do you need to have to even set up a consultation with any one of us? And the answer is you really need to know nothing, and you don't need to have had any prior exposure to any information, and it's really an information session to understand all the options and ask any questions that you have, which hopefully some of which I will address today for all of you. But we have a whole range of folks who come to us to learn about the options to build families, and some know exactly what they want to do when they set up their consultation, and others really don't have any sense and are looking to hear all of the options. So we'll begin talking about some of these options right now. Thank you all for joining or for watching us later, whatever the case may be. I'm going to start with some very basic things about how to help build a family for female-female couples. And some of the first things that we talk about is essentially just natural fertility. And I think it's important to have an understanding of natural fertility so that expectations going through the process are realistic. And just so that everyone knows that usually per month, the chance of conceiving when the sperm once you've ovulated and there's sperm present is approximately up to about 20%. So again, just on a per month basis, people only conceive about 20% of the time at each cycle. And this is certainly not a big number, but one that we hope to get up to when we do things like insemination, and we'll talk about what that means. So 20% per month. And then that usually over a span of 1 year of trying. It's a normal amount of time for there to be a female who ovulates and then have sperm be present. So through intercourse, for example, the 12 cycles of attempting to conceive is considered normal in the sense of measuring one's fertility. And it's really only if one hasn't conceived after 12 months of attempts that's considered abnormal. And that goes for all women who are under 35. Above 35, it's about 6 months of attempting to conceive. So it's important to have that basic sort of understanding and framework when we try to help same-sex couples conceive, because we're striving to maximize the attempts at conception and I'm sorry, to minimize the attempts at conception and maximize the success, but it's really difficult to overcome what is the natural course of things. So any treatment that we offer is going to help try to get us up to that normal number of chance of success. And so the most popular choice is using insemination, where essentially we allow couples to have previously selected sperm donor, and most of the time this is from an anonymous source, so typically sperm banks, and we'll talk about selecting that in sperm banks in just a few minutes. But using sperm that is stored at a facility like ours, that we then would thaw that day that the person is ready for ovulation and is starting the process of ovulation, and then through the process of insemination, inject that sperm into the uterus. And so we try with each attempt, we hope to get everyone up to that 20% per cycle chance. So there are some things to kind of take a step back and talk about prior to getting to that point, obviously, and just sort of giving that framework is sometimes what I even talk about to my patients when we try to say, okay, well, what testing is appropriate? How do we select sperm? How do we know we're getting sperm from a reputable source? All of those things to get to that point. And so what I first tell our patients is that you guys are investing a lot of time, energy, and money And so a lot of times you don't necessarily need to go the route of investigating how your ovaries are functioning. We all think that they would be normal function for anyone else compared to anyone else your age. We try to we talk about, that there's low chance of having any problems with your uterus or your tubes, like there may be for some of our infertile patient population. But because you're investing so much time, energy, and money, it's not a bad idea to undergo a few tests just so that we can make sure that we've optimized every single thing that we possibly can, so that we're not trying to help you conceive for 5-6 months of using this precious sperm, your time, energy, and resources, and then find out that there may be some other issue that we could have known from the beginning and offer different treatment or more effective treatment to help with whatever issue we may have uncovered. So about 10 to 15% of couples or people in general will have some kind of issue with fertility that we can detect with these different tests. So we always recommend that it takes only about 2 weeks to get all of the tests done, and it is timed at a certain part of your cycle. And the tests usually just involve an ultrasound and blood work to look at how your ovaries are working, and then one particular test using an X-ray that can help to make sure that the fallopian tubes that carry the sperm to meet the egg and that the uterus that carries the pregnancy, that those are both normal. And then within those couple weeks of the first part of your cycle, that we would have those answers and then be able to say, okay, great, we've checked these things off. We know that everything is looking good, or we've detected something that we can now offer a more effective treatment to help you conceive. So there's usually a 2-week recommending kind of testing period in the first half of your cycle. And it's also a good time in that month to, after we've answered all of these questions, to really kind of think about selecting your sperm donor. And so what are some of the characteristics that we look at with the sperm donor? And that is typically, we hope that it's from a reputable source, meaning that it's usually an FDA-approved sperm bank, or always an FDA-approved sperm bank. And so there are many, many of these banks across the country and even the world that have plenty of donors that are accessible. And the reason why having an FDA-screened donor is important is because they've essentially undergone a quarantine period where they've had these donors undergo sexually transmitted disease testing, and then the sperm is frozen for 6 months, and then the donors have to get retested to make sure that they weren't in the early stages of having any of these diseases that may not have been detected the first time. And so because they've undergone the quarantine period and then been retested, sort of the best that we possibly can do to make sure that there's little to no chance of having any kind of any donor with any STD that could be avoided. So we highly recommend and really even only use sperm from FDA-approved sources. And really the acquiring the sperm process is pretty simple. You have the information and the address of the clinic that you want to have it sent to, and then essentially get it shipped to the facility, hopefully in the month prior to when you're starting treatment, so that we know that it's there and available. One other parameter that's often discussed, not to spend too much time about it, but that is something called CMV, or cytomegalovirus. And if any of you have looked at sources for sperm before, you may have seen it come up as this donor CMV positive or negative. And the reason why it is something that is tested is because it's a very, very common infectious disease. It's not an STD, but it's an infectious disease that most people would have no idea that they've ever been exposed to it. It has symptoms much like any kind of virus causing a cold. And it's really not of any significance for adults. But the concern is that when you have, if you were to have contracted this CMV during pregnancy, it could have some pretty devastating effects on the growing and developing baby. So because of that, we try to avoid being in contact with anyone who may be having an active exposure or an active infection of CMV when somebody is pregnant. So now how does this relate to the donors? There is a theoretical risk, and I emphasize theoretical risk, that if a donor were to have been exposed to CMV at some point in their life and have antibodies to it, that it's possible that if the recipient, our patient, was never been exposed, that it's possible that if the used sperm of the CMV positive donor and to a CMV negative recipient, that they may contract a CMV infection. I say it's possible, but again, it is theoretical. It is not anything that has been ever documented as occurring. My personal and professional opinion is that there are so many important factors to look at when selecting a sperm donor, as you can imagine, than ethnicity or education, intellectual interests, all sorts of things that, in my opinion, are much more important than their actual CMV status. But it's something to know, because it's something that you will need to know about the donor, and it's something that us in the fertility clinic or any clinic that you would go to would also test for you. So you would know if you were CMV negative or positive, meaning that if you've been exposed to it before, and if it's something that you may need to consider. So that's a longer answer than I intended, but a question that often comes up quite a bit, because it's something that people don't know very much about on their own. So once the sperm has been selected, then it's fairly easily shipped to the facility. And then what happens, typically what we recommend is to get at least 3 samples in one shipment. I think that's a good number. Again, only about 20% chance, 15 to 20% chance using previously frozen thawed sperm in a single insemination, so chance of pregnancy in that one cycle. So it's not uncommon that you might need more than one cycle to conceive. So usually 3 vials of the sperm for insemination is recommended in a per shipment basis. And that's sort of just a general kind of rule of thumb. I have one question that I was asking back to when we were talking about the tests. So what are the tests? So sorry if I wasn't specific enough about it. The tests are an ultrasound that looks at the ovaries and the uterus, blood tests, which look at specifically on day 2 or 3 of your cycle, which looks at different hormone levels. Hormone of FSH made by your brain, always we get that test with an estrogen level. And then another hormone that doesn't have to be at any time in the cycle, where you would have, also helps to look at the ovaries. Sometimes also a hormone that we use is called AMH, or anti-Mullerian hormone. And instead of being made by the brain, it's made by the ovaries. So those 3 things, the FSH, the ultrasound, the AMH, help us see how the ovaries are working. And then that other test I was mentioning is HSG, or hysterosalpingogram. That is the X-ray test that I had mentioned. So I apologize if I wasn't specific enough to describe what those tests were. The HSG, the X-ray test, is the one that looks at the tubes, as well as giving us some information about the uterus to make sure that all of that looks normal. So again, if anyone has any questions, please feel free to make a comment, and I will absolutely answer them. So often, like I mentioned, the most typical scenario is that undergo the test that I just mentioned, and then we get some additional FDA-required blood work, which includes testing for HIV, hepatitis, a particular blood test that looks at exposure to syphilis, the CMV antibodies that I mentioned, and then also the routine preconception things that if you were to go to any OBGYN and say that you're interested in conceiving, we want to make sure that you're immune to things like chickenpox and rubella, that you've had appropriate counseling regarding potentially getting any kind of carrier screening for common things like cystic fibrosis or anything that may run in your family. A lot of times that when you look for donors, that they will provide some of the genetic testing information. It can be variable, the extent to which how many diseases were tested for. But certainly if we find that a donor that a couple or a person is interested in does have a carrier status for a particular disease, then certainly we can test for that to make sure that you yourself or your partner doesn't have it. So again, the most common route is to do the intrauterine insemination. And so the actual IUI is done, again, at the time of ovulation. So how do we figure that out? I said the way with the least sort of intervention is for you at home to detect the natural surge, meaning the hormone level, LH or luteinizing hormone, is what the urine kits, the ovulation predictor kits that are sold in drugstores, detects. And what happens is the LH hormone is secreted in your bloodstream, and then it shows up in your urine, and then within about 24 hours of that test being positive, a woman would ovulate. And so typically, the least sort of intervention type way of going about this is you monitor on the days that would be appropriate for the length of your menstrual cycle with ovulation kits, and then when that kit turns positive, you can call the office and then have that have an insemination scheduled for that following day after the LH is positive. And then you would come in that morning for the insemination. And when in the office, we thaw the specimen, and then it's just about a half a milliliter of volume of the sperm concentrated, and with a speculum in the vagina so we can see your cervix. We take a tiny, tiny little catheter through the opening of the cervix. Most people don't feel anything at all, and then inject the sperm. And then you just carry about the rest of your day as you normally would. And then you would either get a period within the 2 weeks, or if not, certainly we test for pregnancy and then go from there. And then it sort of there's a stepwise progression. So we can either decide to do that with LH monitoring, or you can potentially have more monitoring with ultrasounds and blood work that we would do in the beginning of a menstrual cycle, and then around the time that you might be ready for ovulation, usually around day 12 in a 28-day cycle, day 1 being the first day of a period. And then that gives us a sense of when the best time might be, and helps us pinpoint the best time, and can increase chances of pregnancy in some sense, because we know we're optimizing the timing of everything, as it needs to be so precise, since we obviously only have usually one shot in that cycle. Other ways is that commonly a lot of women elect to use a fertility medication, such as oral medication like Clomid or Letrozole, along with a one-time injection to make one ovulate when we see that by ultrasound and blood work that looks like the egg would be mature, and be able to time it that way. So a lot of times we give instructions to take this one-time injection, and then either the following day or within 36 hours, time the insemination. So depending on the patient's preference, or on the patient's age, or on how aggressive we wanted to be with the time that we have, all of these options are available, and then basically go from there. Typically, after 3-4 months of trying one particular method, we always suggest reviewing the treatment plan more formally, and then at that point, changing the plan a little bit to help increase chances. So I see there's a couple more questions. So unfortunately, in terms of the chance of conceiving, so age is one thing that 100% of the time, as one ages, the fertility goes down. And unfortunately, since women are born with all the eggs that they have, they only lose eggs every day throughout the course of their reproductive lives. Both the number of eggs is depleted, as well as the quality of the eggs as they age diminishes. And so at 46, it would be probably, I would say, at that point, less than 5% chance overall, maybe closer to 1 to 5% chance of conceiving. But there are many other options, including donor egg at that point, that can be quite successful. Another experience, thank you for the comment, Ms. Bird, thank you. Glad you guys had a good experience. So another option that is open to couples that some do, but certainly fewer than who choose inseminations, but some couples do choose this, is something called co-IVF, which is The process by which we obtain eggs from one partner, and then create embryos using donor sperm, and then place an embryo back in the other partner's uterus to then hopefully become pregnant and carry the pregnancy. So that recipient parent, the one whose embryo was placed in their uterus, the recipient parent is not genetically related to the child that they're carrying, but is created of the eggs from their partner, and then as well as the donor sperm that they've selected together. So it's a very nice way, in my opinion, for both members of the couple to play a quite significant role, obviously, in creating their family. But obviously, in terms of what's involved, which means IVF to obtain the eggs, IVF being in vitro fertilization. So the one partner would undergo a process of a series of injections for over average of about 10 days. And then an egg retrieval, which would be under IV sedation, where through the vagina, we use a needle to get all of the eggs from the ovaries. And then we combine the eggs with the donor sperm, create embryos, and then we select the best looking embryo to be placed back in the uterus of the other partner. So during this time, that other partner has been taking estrogen, usually orally, as well as with a patch. And then a few days before the planned embryo transfer, and starts with injections of progesterone. And this is all to help prepare the lining of the uterus to get ready to accept the embryo and hope for pregnancy. So again, it's the best way for both members to have a role in the child creating and bearing process. And sometimes then this would be an option for couples who may have already chosen and been successful with insemination first, or potentially choose to do that at a different point, depending on who wants to carry the pregnancy. So I'm very happy to answer any questions for you guys. I see lots of folks from our practice, all eager to be supportive and hear what we're all talking about and questions that you may have. So hopefully if anyone has any particular questions of things that we haven't touched on, I'm more than happy to answer them. We have about 7 or 8 minutes left here. So if anyone has questions that they would like to take offline, please feel free to contact myself or anyone else in our office. And you can do that by several ways. One is there's an Ask a Doctor questionnaire or on the off of the homepage of our website. There's also a phone consultation, and certainly, of course, the making an appointment for a sit-down conversation and consultation where you can review all of the options and everything we talked about here. So if anyone has any more specific questions regarding anything that we're talking about, please do let me know. And I look forward to answering any other questions that you may have. Okay, we have another question. So usually, as long as there is so the question is not necessarily as related to age, but how successful can insemination be, or chance of pregnancy with one working fallopian tube? Usually we say that if there is a working fallopian tube, there's not so much of a quotable difference in the chance of success. So the 20% per month is pretty much with everything intact and working. I mean, if we had to pick a number, I would probably say a little bit lower than that, maybe the 10 to 15%, maybe 15% in all comers. So that's a per month basis average across the board for all reproductive age women. But as I mentioned, I understand it can be confusing because the overall chance of pregnancy does decline with age, as does the per month chance of pregnancy. So these are all averages that I was mentioning before. But usually when you have one working fallopian tube, that might be an opportunity for us to help in the sense of trying to get more than one follicle with an egg inside of it develop, with the hope that that we can optimize that one working fallopian tube and that we have an egg that is available on the side of the working fallopian tube. So the cost of inseminations, that is a good question. So the cost of inseminations on average roughly between $300 and $400 for the actual insemination. And then the success rates, as I mentioned, so 20% being when fresh sperm is available with in a natural cycle of an ovulatory woman. And usually we quote a little bit lower using previously frozen thawed sperm. So somewhere between 15 to 20%, roughly about 15%. But anything that we do using Clomid or other medications is an attempt to get up to that 15 to 20% chance of pregnancy per month with insemination. And let's see, so that brings, at what age is IVF pregnancy possible? So usually the recipient, the person who is going to carry the pregnancy, usually up to an age of about, I believe around 50 at this point, occasionally a little bit older. The person who we're attempting to retrieve the eggs from, success declines pretty rapidly after the age of 40. And I would say that between 43 and 44 is sort of the upper limit of when most clinics, including ours, would consider doing a retrieval and hoping to get any viable eggs. So that's a very good question. I didn't mention yet about male couples, and I certainly mean to do so. So typically there's a lot of planning that's involved, as you can imagine. So obviously we have sperm available. We usually would do a semen analysis just to make sure that we can expect that would be normal. And then there is a selection process, usually with either known or anonymous egg donors, that we have a whole egg donor team and coordinator that helps facilitate that process. And then we go through the process of IVF for the egg donor and use the sperm from one or even both of the male partners to inseminate the eggs that we retrieve from the donor and create embryos. And then we also have at that point lined up what's called a gestational carrier, which is a person who's intended to carry the pregnancy. And that person will have taken medication, estrogen and then progesterone, to prepare the lining of their uterus. And then when the embryos are ready and the carrier is ready, we place the embryo back using it in the embryo through an embryo transfer. And then again, hope for pregnancy. So that is a very involved process with a lot of coordination, but certainly can be very successful and very very rewarding process to help a couple go through. So again, if you guys have any other questions for a few more minutes, if you want any other questions answered, also including cost and more information about the process, we do have a LGBT family building site off of our homepage that helps to get a little bit more information about everything that we talked about, and now always available to answer any questions. And I mentioned a few ways, either through the Ask a Doctor or setting up a consultation. I'd be more than happy to answer any questions that you may have along the way. And we look forward to helping anyone who's interested to embark on the very exciting journey of building a family, and hope to see you all soon. Take care.